Good morning, everyone. My name is Gülce, and I'm a PhD student at Boğaziçi University at Esin Hocas Lab. And today I will talk about the ongoing studies on the DEBBIE and TACTIX projects in Türkiye. So the first project is DEBBIE project, and the DEBBIE project is aimed at developing a direct and non-invasive clinical imaging biomarker called BBB-ASL. To map the loss of blood-brain barrier integrity in the preclinical stages of Alzheimer's disease and brain tumors. And in Boğaziçi University, with the collaboration of Acıbadem University, we are working on brain tumors, meningiomas, and gliomas. Gliomas are the most common type of malignant primary neoplasms in adults, and accurate histopathological grading and subtyping of gliomas are crucial for optimal treatment planning. The latest edition of WHO CNS5 categorizes adult-type diffuse gliomas into 3 groups, which are astrocytomas, oligodendrogliomas, and glioblastomas. And IDH mutation is a marker for low-grade gliomas with better treatment responses and better survival. The blood-brain barrier regulates the transfer of essential nutrients into the brain, and the breakdown of the BBB is commonly seen in high-grade gliomas and brain metastasis. And it's typically assessed using post-contrast T1-weighted MRI. However, subtle changes in BBB integrity may be missed due to the molecular weight of the contrast agents. The BBB-ASL is a new technique that can be used to assess BBB disruptions at a larger range. BBB-ASL is a specialized MRI technique that extends ASL to evaluate cerebral blood flow and BBB permeability through exchange time, which is the time that it takes for labeled water to cross BBB into the tissue. It is non-invasive, which means that there is no need for contrast agents. And higher CBF means hyperperfusion, we commonly see on the tumor region, and the lower CBF means hyperperfusion, which we observe in the necrosis. And lower TX means increased BBB permeability, while higher TX means intact or reduced water exchange. The previous applications of the BBB-ASL, which were based on a constant T2 value across the entire brain, had their limitations. A constant T2 value may not accurately represent tumor tissues due to their heterogeneous nature and increased vascularization. And monoexponential T2 fitting is sensitive to changes in BBB integrity and can help distinguish glioma subtypes and assess treatment responses. So our aim in the glioma study is to identify IDH mutational subgroups of gliomas using CBF and TX maps and examine the impact of tissue-specific T2 on both CBF and TX maps. We are acquiring the data at Acıbadem University Altunizade Hospital with a Siemens 3 Tesla MRI scanner equipped with a 32-channel head coil. This far, we acquired multi-modal MRI data from 25 patients with histopathologically confirmed gliomas, and the pathologist with 13 years of experience performed this pathological analysis. We are using 2 sets of Hadamard Picasso sequence with 3D Grace readouts, a single TE Hadamard 8 matrix with sub-bolus duration of 400 milliseconds and post-labeling delay of 600 and 800 milliseconds, which results in 3 sets of 7 TIs, and a multi-TE Hadamard 4 matrix with sub-bolus duration of 1000 milliseconds and post-labeling delay of 500 milliseconds, which results in 3 TIs. We then use Explore-ASL to concatenate these 2 sets of outputs. And for T2 fitting, we use the control images of Hadamard 4 sequence. Here, SI is the array of control images acquired through the multi-TE Hadamard 4 sequence. S0 is the proton density image, and TEI is the array of echo times. We perform manual segmentation on FLAIR images for whole tumor segmentation. And we use post-contrast T1-weighted MRI to identify necrosis. We then perform bias field correction and skull stripping, and post-contrast T1-weighted images, FLAIR, and tumor masks are registered onto CBF and on CBF using SPM. We have 2 groups, IDH wild type and IDH mutant, and the age values were significantly higher in the IDH wild type group, and the sex distribution was similar in both groups. We have 10 IDH mutant tumors in our cohort, and all of them are grade 3 astrocytomas, and 15 IDH wild-type tumors, all of them are glioblastomas. Here we first calculated the tumor-specific T2 values by using the T2 maps. We then calculate CBF and TX maps using these T2 values. These images are one slice from 5 different glioma patients. Patients 1, 2, and 3 have IDH wild-type tumors, and patients 4 and 5 have IDH mutant tumors. In IDH wild-type tumors, we observed higher CBF values at the lower percentiles, and IDH wild-type tumors exhibited lower CBF energy, and IDH wild-type tumors exhibited lower time of exchange energy values. This is the scatter plot for the 5th percentile of T2-corrected TX and CBF, and IDH mutant tumors clustered at lower CBF range, and IDH wild-type tumors showed a wider distribution of CBF values. And TX values were higher in the IDH mutant gliomas than the IDH wild-type tumors. Second, we perform BBB-ASL on meningiomas, and meningiomas are the most common primary intracranial tumors, and perfusion MRI has been used to assess grades of meningiomas, measuring CBF in the tumor region. Our aim in meningioma study was to examine the impact of tissue-specific T2 on both CBF and TX maps. We only have 4 grade 1 meningiomas and 2 grade 2 meningiomas. Our cohort is really small, therefore we could not try to identify the differences between the mutational subgroups or grades. So we checked the effect of T2 correction in meningiomas. We use the same formula in a meningioma cohort. So when tissue-specific T2 values were used, we observed increased mean CBF in the normally appearing gray matter and increased mean CBF in the tumor region. And for TX, we observed increased mean TX in the normally appearing white matter and decreased mean TX in the normally appearing gray matter and decreased TX in the tumor region. So our results support the potential of multi-echo BBB-ASL for evaluating BBB integrity and identifying mutation subgroups of gliomas. However, the limited sample size in our study may have affected the statistical power to detect significant differences in exchange times. So future research with a larger patient cohort is needed to investigate BBB water exchange rates in gliomas. And exploring BBB permeability alongside other imaging biomarkers could enhance understanding of glioma biology and treatment responses. Finally, our results demonstrated that BBB-ASL technique incorporating tissue-specific T2 values can measure CBF and TX to assess tumor permeability in meningiomas. Second part of this presentation is the TACTIX project. The TACTIX project addresses the urgent need for new imaging biomarkers to detect subtle brain changes in multiple sclerosis patients. It aims to enable early intervention and support personalized treatment strategies through advanced MR imaging techniques. The initiative focuses on developing biomarkers that capture subtle changes in BBB integrity. The consortium includes Boğaziçi University, Fraunhofer MEVIS, and Amsterdam University Medical Center. MS is an autoimmune disease for central nervous system and is characterized by demyelination and neurodegeneration, and breakdown of the BBB is one of the hallmarks of MS. Post-contrast T1 weighted MRI has been used to identify leakage of BBB in MS. However, again, due to gadolinium's higher molecular weight, post-contrast T1 weighted MRI might miss subtle BBB changes. And this initial study efforts to investigate BBB permeability in MS patients, focusing on both lesions and normally appearing white matter using BBB-ASL. Again, we acquired data at Acıbadem Altunizade University Hospital from 7 patients and 2 healthy volunteers. We again used Explore-ASL to quantify CBF and TX maps, and this time we performed automatic segmentation of the lesions. We observed that the mean 10th and 19th percentiles of CBF values in the lesions were higher compared to normally appearing white matter, and the TX values in the lesions were higher when compared to normally appearing white matter. However, these results were not statistically significant due to our small size of samples. So in this initial study, the BBB-ASL method has been utilized to evaluate CBF and TX values in the lesions of 7 patients with MS, and increased CBF in flare lesions compared to the normally appearing white matter is consistent with the literature, and increased TX in the lesions compared to the normally appearing white matter agrees with prolonged mean transit time. However, it was not statistically significant and it needs further investigation. So future studies will focus on investigating the BBB-ASL for evaluating perfusion metrics in a larger patient cohort. And up to today, we have published 6 abstracts And we have submitted 2 more to ESMRMB, and the glioma paper is on the way. So, thank you.
How do we perform automatic segmentation in multiple sclerosis disease?
Question is, how did we perform automatic segmentation on multiple sclerosis? We use the lesion prediction algorithm LPA and the lesion segmentation toolbox, and we used CAT12 for white matter and gray matter segmentations using XPM.
And did you perform registration methods?
Yes, we performed this on the flare images, and then we registered those onto CVF maps.
It's not so important, but are you sure about the registration is correct?
We have neuroradiologists on the way, on the group, so we are always confirming our segmentations with them.
No, I'm not talking about segmentation, I'm talking about registration.
After registration as well. I mean, we are checking it.
Right, usually.
Yeah, usually. Yes.
I wanted to ask you about when you are giving the CVF and tissue exchange time, you are using percentile. What do they
Yeah, instead of mean and max, we are using lower percentiles and higher because minimum and maximum values are single values, which may be incorrect due to the vascularization of the tumors. So we are using lower and higher percentiles instead. Yes.
Your post-processing, I mean, you know it now from the DEBBIE project probably, and also now in TACTIX. So how much interaction does it need if you get a data set from the patient or volunteer, and then feed the data into XPRIZE? How long does it take roughly? I mean, we have also done here.
How long does it take to process a patient in XPRIZE?
Yeah, and how interactive? So how much interaction do you need? So how much manual adjustment parameters can you
especially for the T2 changes, I need to enter T2 values for each patient, like for 25 patients. So I need to be in front of the computer for a day to perform all.
And you enter T2 values based on literature, or you measure T2?
We measure it for this study. But we are now using 116 milliseconds for Glioma, which is measured by the Munich group.
So you measure it for each patient, or you?
Yeah, but for what I told here, we are measuring it, but we decided not to anymore, actually.
Because they are similar always?
Yes, and it is. It's a challenge to perform the T2 correction. Mono-exponential fitting is not sensitive enough. So. Yeah. Okay, thank you.